Okay, so today we'll start a new series, and it's really important because it's one of the pillars, one of the important part of intensive care is how to support the breathing of a baby or a child, and how to do that in a correct way, getting the best benefit and minimizing the side effect. Okay? Are you guys ready to go?
Yes.
Okay, so let's start. Okay, so when we assessing and monitoring the breathing, we do it clinically. So we look for nasal flaring. Do you guys know what's nasal flaring? Or I should explain?
Yes, I know. When you try to get more air, your nose will be, I don't know how to explain.
Yeah, so
And
your
inflate
the
and
outside, yeah, the outside of the nose start moving up and down. Okay, it's like a flaring, it's like a flying, okay? So the nose has outside uh, wall called ala, and the middle one called calamella. So the ala nasi is the outside of the nose, start moving, okay? And what's grunting? Do you guys remember what's grunting is?
I think it's yani when you try to breathe more and effectively and
Okay,
it's not
so
like
grunting is reverse of the breathing cycle. Grunting is reverse of breathing cycle. Normally we breathe in, then we breathe out, then we pause. So we do like that. And then we pause. And then we do like that. So we pause after we exhale. We pause, we stop breathing after we breathe out. The reason because we know that we have fat, we have oil, we have surfactant in our lung, and we know our lung will never stick. So when we lose that fat, the lung will become sticky. And when we breathe out, it will stick to each other and will collapse. So we reverse the breathing. So we breathe out, then immediately we breathe in, and we pause after we breathe in. So we do like that. So we pause when the air is inside. So grunting is not respiratory difficulty, is not retraction, is not intercostal recession. It's a reverse of respiratory. When we say grunting, meaning the surfactant either deficient or decrease. So it's either RDS or ARDS, adult respiratory distress, with different causes. Now, do you understand what's grunting? Do you understand what's grunting? Or I should explain it again.
no, I think it's clear.
Yeah, so please remember, grunting is not respiratory difficulty. Respiratory difficulty when you need more air or you need more oxygen. Grunting when your lungs stick. So when you call me and you say grunting, I understand that we have to give surfactant. So remember that. Okay, please remember that. Grunting is not mooning. This is not grunting. And grunting is not wheeze. This is grunting is not croup. These are not grunting is okay, reverse of respiratory cycle. So don't use the words and you don't know the meaning. Okay. So that's clinical. We look at the grunting, we look at retraction, we look at tachypnea, we look at cyanosis, we look at abdominal breathing, we auscultate, we look at the air entry, we look at the type of the sound, as we've discussed in the sick child. So that's clinical, but also we can do X-ray. and ultrasound. And in future, when you work with me, I will teach you how to read the X-ray. We do blood gas also. But also we monitor the baby non-invasive by monitors. So we check the saturation by pulse oximetry. We use NIRS, near infrared spectroscopy, to check tissue oxygenation. So saturation by pulse oximetry, NIRS tissue oxygenation. We also use transcutaneous oxygen. We use transcutaneous carbon dioxide. We use end-tidal CO2, and we use capnography. We'll discuss these. These called non-invasive blood gas monitoring. We also look at the variables in the monitor of the ventilator. The dependent, which depend on what the clinician, a nurse, or a doctor said, and the patient interaction. That's called dependent variable. And there is independent variable, those the operative set. So dependent is the result of interaction between what you said and the baby or the child, and independent, only those you are at. So you monitor both the set and the monitor. We look at the graphics and we look at the loops. So this is how we monitor a baby in a respiratory. Now, blood gas, we have three types. We have arterial, we have venous, we have capillary. The best is the arterial, but also we can use capillary, and the least important are venous. We use pulse oximetry, and pulse oximetry measure oxygen attached to the hemoglobin, oxyhemoglobin. And when it's ranged between 88 and 93, the arterial pressure, the oxygen pressure, PaO2, measure the oxygen dissolve in the blood, while oxygen saturation measure wait 1 minute. Okay. So please remember that pulse oximetry measure the oxygen attached to hemoglobin, while arterial blood gas, capillary blood gas, venous blood gas measure the oxygen dissolved in the plasma. So when the reading by pulse oximetry, the saturation is 88 to 93, the same reading in the dissolved blood by the blood test, by the ABG, is 80 to 40 millimeter mercury. Because the saturation, the pulse oximetry, measure percentage from 0 to 100, so when it's high or low, become less accurate. So exactly when you bring mizan to measure fruits or vegetables, if that mizan is measured from 0 to 200, the best value for this mizan is 100. When it become 101 kilo or 99, become less accurate. When it become 110 or 90, become less accurate. When it become 150 or 50, become less accurate. And least accurate when it's 1 kilogram or 200. It's because it's percentage. When it goes to the periphery, it become less accurate. Now, is that clear for pulse oximetry?
Yes, but doctor, do we get the same result from VBG and ABG?
No, we'll talk about that later. We have a session about interpretation of blood gas.
Tamam.
We have a whole session, a complete session. How to read, how to change the, when to call, how to escalate, how to decrease the support based on the blood gas, and what we will do, what is the benefit. We will do a complete session on a gas. Okay?
Okay. Okay.
Now, what are the advantages of the pulse oximetry? Because it's use light emitting, it emit light, it will not damage the skin. So we don't need to change the location. So that's one. Second, it does not need calibration. So you don't need to recalibrate every 6 hours. The reason, because it does not measure numbers, it gives you percentage. And it does not affect by skin temperature and perfusion. It affects, but not like other non-invasive measures. A disadvantage, the patient movement, the light, and the frequency, like mobile, like TV, affect the result. Light and movement and frequencies, okay? The other disadvantage, it only measures the oxyhemoglobin. The rest of the hemoglobin that is not oxy, like carboxy, connected to hemoglobin connected to the carbon dioxide, or methemoglobin connected to monoxide, or silver hemoglobin, or M hemoglobin, which is abnormal hemoglobin. It does not tell you. It does tell you that what is the percentage of oxyhemoglobin from total. So when there are more abnormal hemoglobin, it will be incorrect. Now, do you understand the pulse oximetry limitation and advantage and disadvantage? Now, also we have transcutaneous oxygen. The difference from pulse oximetry, it measures number, not percentage. And it used electrolyte solution and oxygen permeable membrane. It is electrochemical sensor. And because it measures number, it need recalibration every 4 to 6 hours because start to give you wrong reading. And because it's electrochemical, it causes thermal damage to the skin, especially in a premature baby. And it affects by perfusion more than the pulse oximetry. So shock, acidosis, hypoxia, hypothermia, edema, anemia affect the result. Okay? The advantage, it gives you number, not percentage. Other advantage, it also measures the oxygen dissolved in the plasma, not only the oxyhemoglobin. Transcutaneous CO2, exactly like transcutaneous oxygen, no difference. But here measure oxygen, here measure CO2. And tidal CO2, it measures the oxygen in the tube, the carbon dioxide in the tube. And it measures the end of tidal volume. So the end of inhalation, the beginning of exhalation. And tidal. Tidal means tidal volume. So the end of the volume that we get it in. Okay? And here show you how we measure it. So we measure it at the end of inhalation. When the tidal volume become max, end tidal CO2. And it measures the CO2 in the alveoli. Now, do you understand the non-invasive blood gas monitoring? Any question about that? Now, there are other non-invasive, which is the NIRS, but it's difficult technology. So and we don't have it here, but when I bring it, I will teach everybody how to use the non-invasive NIRS. Okay? And tidal CO2, there is benefit and disadvantage and limitation. The benefit is it's available. Second, it gives you continuous recurrent information, because when we measure CO2, we measure the gas every 8 hours, every 6 hours, maximum every 2 hours. So you have CO2 only every 2 hours. The end-tidal CO2, you have it continuous. Also, it's real, not like there is no lag between the measure and the reality. So when we do transcutaneous CO2 or transcutaneous oxygen, the number that you see in the monitor is about like 5 seconds later than the real lag time, they call it. In the end-tidal CO2, there is no lag time. The problem, it takes space. So remember that the tubes and the airways, there is air. And this air is not giving us a gas exchange. That's what we call it dead space. So when you put another space, it increases the dead space. And the dead space are very important in very small babies. Because if we deal with 1 kilogram baby and the tidal volume is 3.5 mil, so you have only 3.5 mil. So if you add 0.5 mil, affect the baby. Another problem, because it measures at the end of tidal volume, when you have high rate, the expiration will be short. The time of the baby is not breathing will be very short. So this breathing cycle will be attached to the other one. So it affects the result. So that's why one, it gives us dead space. Second, it's not good when the baby is tachypneic, and it's not good in a premature baby. Advantage is continuous and it's non-invasive. We don't need to do blood gas and it's not expensive. Okay, other monitoring, remember we said there is variables. So in the ventilator, we have control. Inshallah, we'll take it when we do invasive. We have control. So the control will tell us, is this volume control or pressure control? We have variables, and the variables are different. There is phase variable. The phase variable is tell the machine when it will change from inhalation to exhalation. But also there are the other variables, we call it dependent and independent variable. The dependent variable is the measure. It results from interaction of the machine and the baby. The independent is the values you set. An example of independent is the FiO2. FiO2 is the fraction of inspired oxygen. And we give from room air to 100%. We can write it like this, but also we can write it like 0.21 to 1. So 90 or 0.9. We can, either way is correct. So that's how we write it. And remember, FiO2 is independent variable because you set it. Any question here? Please ask question, even if you think it's silly. If you don't understand, I will repeat.
Doctor, it's not in this slide, but you mentioned dependent and independent. I didn't get what's the difference.
Dependent is the number that you set in the ventilator. So you'll tell the machine respiratory rate is 40, PIB is 20, PEEP is 6. All are independent. It's by the machine. That's called independent. The dependent is the number you read in the monitor, the measured one. Called dependent because it depends on the independent that you set and the patient interaction with the independent. So it depends on the machine and the baby. So it's called dependent variable. واضح؟ لو أعيدها مرة ثانية.
لا أنا فهمت.
Okay.
بس خش.
So airway depend on two things, dependent and independent variable and the type of the breath. So we have three types of the breath. We have mandatory machine delivered breath, not affected by the baby. We have spontaneous patient delivered, not affected by the machine. And we have assisted breath. It's a combination of the patient and the ventilator. So based on the type of the breath and the dependent and independent variable, we got the airway pressure. Airway pressure are different types. The first airway pressure, called PIP, peak inspiratory pressure, is the pressure that the maximum pressure during inspiration. Is that clear? What is PIP? Question?
Yes, it's clear.
It's very vital to ask question. Please don't keep silent if you don't understand. I can repeat it hundreds of times. I am here to teach you, not to feel shy. Please ask question if you understand. Okay, so the second airway pressure called PEEP, it's a peak and expiratory pressure. And the pressure, whether it's PIP or PEEP, is measured by centimeter water. And when we say 5, the ventilator meaning that the 5 above atmospheric pressure. So the ventilator consider the atmospheric pressure 0. But in reality, the atmospheric pressure is 760 millimeter mercury, or 1024 centimeter water, or 70 kilopascal. Is all the same, but different values. For the ventilator, this number, the atmospheric pressure at the sea level, is 0. Anything provide above atmospheric pressure called airway pressure. And they are two types. They are PEEP and they're PIP. The PEEP is the pressure that is during expiration. And the PIP is the pressure that is during inspiration, called PEEP and PIP. And the PEEP is of 5 types. Now, I will teach you later what are the types, but it's the internal PEEP or physiological PEEP, which is 3 to 4 centimeter. The applied PEEP that we apply to the baby, the auto PEEP, which is created by certain diseases such as asthma, okay, and the internal PEEP, which is created by the patient. So there are 5 types. We'll talk about them later. Right now, just understand. A pressure above atmospheric pressure provided by the machine to the baby. And the atmospheric pressure is 760 millimeter mercury. For the machine, these are 0. Anything above it is called airway pressure. And they are of 2 types, PIP and PEEP. Now, do we understand? Or I should repeat?
Yeah, doctor, if you can rotate it.
I can repeat.
Difference.
So the airway pressure are pressure provided by the machine to the baby. It's a force of air pushed to the baby. We call it airway pressure. Now, there are variables to control the breathing provided by the machine to the baby. These variables are of 2 types. The first one called phase. Phase mean time, mean changing. Phase variable tells the machine when to start and when to stop, when to start inhalation, when to reach maximum inhalation, when to end inhalation, when to pause, when to start exhalation, when to start maximum exhalation, when to end exhalation. These are called phase variables. The other variables called dependent and independent variable. The independent variable is the number that we set on the machine. It does not affected by the baby. The dependent variable is affected by the baby and the values that we set on the machine. And that's why the dependent variable is the number that we read from the monitor of the ventilator. So you can see later on that we have 2 types of variables. The one we set at the bottom of the machine, and the one we read usually on the left side of the machine, on our right side, on the left side, usually. So these are the measured, the dependent variable, affected by the machine and the baby. The independent is the variable that we set. So these are the variables. There are other items that affect the machine called breathing type. So we have mandatory, delivered by the machine, spontaneous, delivered by the patient, and assisted, started by the machine, by the baby, and completed by the machine. So based on the airway, which is the pressure provided to the baby above atmospheric pressure. So any pressure pushed by the machine to the baby above atmospheric pressure is called airway pressure. And for the machine, the atmospheric pressure at the sea level which is 760 millimeter mercury, or 1024 centimeter water, or 70 kilopascal, all the same number but different measuring unit. Anything above this provided by the machine to the baby called airway pressure. And the airway pressure are two types. PIP, which is a pressure provided by the machine above atmospheric pressure during inspiration. PEEP is the pressure provided by the machine above atmospheric pressure during expiration. Clear? Or I can repeat again.
Yes, clear.
Okay. Now, if you look here, we have a parameter, which is the pressure, and here we have time. You can see time. So we have here parameter called pressure, and we have time here. And this called a graph. So any picture composed of a parameter, like a pressure or a volume or flow, and time, it's called graph. And you can see on the graph, you see more than one respiratory cycle. This is one, this is two, this is three. So that's why it shows us more than one cycle. And that's why it gives us the trend. But it only shows us one parameter against time. It does not compare one parameter against another parameter. So that's we call it a graph. And in the graph, we will see different shapes. Now, with time, I will teach you what is the shapes. Okay, I won't discuss the shape right now. But when you work with me, I will teach you what does it mean each shape and how we behave with each shape. But right now, just understand that a graph is a parameter against time, and it shows us more than one cycle of breathing. Okay, so we said there is PIP and PEEP. But if we combine PEEP and PIP, we have what we call it area under the cave. You look at the colored area. This is called MAP, mean airway pressure. And you can see it composed of the PEEP, of the PIP, and also the respiratory cycle. That's what we call it, the MAP. So again, airway pressure, PIP, PEEP, MAP. There are three values. Don't look to the shapes. Forget the shapes. PIP is the pressure provided during inspiration. PEEP is the pressure provided during exhalation. MAP is the accumulation of everything. The PIP, the PEEP, the rate, and the duration of the PIP, or the inspiratory time. So all affect the mean airway pressure. So you can see the mean airway pressure is the flow, time, PIP, and PEEP. All affect the MAP. But you don't need the equation. Don't look to the equation. But MAP is the result of PIP, PEEP, rate, inspiratory time. All give us the MAP. And the MAP called the area under the curve, the area that is colored. I should repeat if you don't understand. It's very vital to understand this before we move. So you can see I, inhalation, PIP, E, exhalation, PEEP. MAP is inhalation, exhalation rate, and inspiratory time. This is called inspiratory time. This is called expiratory time. Inspiratory time, expiratory time. Inhalation, exhalation. MAP is rate, PEEP, PIP, and inspiratory time. Questions, please ask question before we move. If you don't understand, I should repeat. I will never move, and if you don't understand. Questions? Questions? Any question? Please ask if you don't understand.
Wallah,
Okay.
doctor, there's just عفوا.
Well, please.
But in the PEEP and PEEP and PEEP and the atmospheric
and PEEP.
pressure.
PIP and PEEP, okay?
PEEP and PEEP, okay. And the atmospheric pressure in the other slide, يمكن.
Okay. This one.
This one.
Okay, what's the question? Do you want me to repeat or there is a question?
Just يعني كرتي.
Oh, let's go back. So we have airway pressure. What is airway pressure by the machine? It's any pressure above atmospheric pressure. Is that clear?
Yes.
Okay. Atmospheric pressure is 760 millimeter mercury. Is that clear?
Mm-hmm. Yes.
For the machine, the 760 is zero. Anything provided by the machine above this zero called airway pressure.
Uh-huh.
Airway pressure are three types: PIP, PEEP, and MAP. Okay?
Okay.
PIP is the pressure provided during inspiration. It's the positive pressure above atmospheric pressure during inspiration. And it's measured by centimeter water. PEEP is the pressure above atmospheric pressure provided by the machine to the baby during exhalation. MAP
Okay.
is the combination of both, mean airway pressure. All of them called airway pressure.
تمام. I got it والله. That's all.
Phase variable is the variable of time that change from it's tell the machine when to give in, when to stop, when to give out, when to pause, called phase variable. Clear? So based
It's
on
clear.
the phase variable, we have three types of the breath. We have mandatory, spontaneous, and assisted. So this is the atmospheric pressure. This is zero. Here, positive pressure. And here is the time. So if during exhalation, like in here, it's called PEEP. Inhalation, it's called PIP. Both of them, we call it MAP. So PIP provide during inhalation, or called I, inspiratory time. PEEP provide during exhalation. Great. This, you can see this, called graph. And the graph is a parameter, which is the pressure here, against time. And it shows more than one cycle. Because it shows more than cycle, it shows the trend. No? So PIP, PEEP, and all of this color called MAP. It composed of PIP, PEEP, rate, and inspiratory time. So you can see there are different type of. So the graph, here is the graph. Here's another graph like it looks in the machine. So that's how it looks in the machine. Now we will not talk on the details of, because we'll talk later. This is a little bit difficult topic. But graph is a parameter. You can see here is volume. You can see here is a flow. You can see here is a pressure. So it's a parameter against time. That's what we call it, graph. The important of the graph, it shows us more than one cycle, so it shows the trend. Now, don't look at the other details. It's not the time. I'm just showing you a graph. Do you understand what is a graph? So graph, a parameter against time. There are three parameters: volume, flow, and pressure. Is that clear? Is there any question here? Loops is not against time. It's a parameter against parameter. And don't look to the details. Just remember, parameter against parameter. So you can see here is volume against pressure. Volume against pressure. And you can see it's one cycle. It does not show us the trend, because it only shows us one cycle. And that's why it shows the dynamic, the changes in one cycle. I will teach you later how we use loop. But right now, I just wanted you to understand. Loops mean one parameter versus one parameter. Graph is one parameter against time. Loop tell us something within one cycle. graph shows us more than one cycle, but it does not show us what is inside the cycle. It just shows us the change between one cycle and another. Now, do we understand loops and graphs? Questions? If you don't understand, please ask me. Okay.
It's clear.
Compliance and
Understand.
resistance, I will pass it at this time. I don't think we'll teach you later. Tidal volume is the volume going to the baby in one cycle, and it measured by mil. Okay, tidal volume, it measured by mil, and it's the amount of air, the volume of air going to the baby in one respiratory cycle. That's tidal volume, and measure in mil. And usually we say it mil per kg. Oops. Now, do we understand what is PIP? Anybody now don't know what is PIP? Peak inspiratory pressure. Please, everybody, talk to me, huh? Don't stay silent. One by one. If you understand what is PIP, do we understand what's PIP?
I understand. Oh, it's clear.
Anybody did not understand what's PIP? What's PEEP? What's airway pressure? What's MAP? What is the type of breath? There are three. What's tidal volume? What's loop? What's graphic? At this level, I don't need more than this. PIP, PEEP, airway pressure, MAP, graph, loop, tidal volume. Right now, this is what I want from you. Any other things in the slide, I don't want you to know. You will know it later. Now, finish monitoring. So how we monitor a baby? We do clinical, we do lung ultrasound, we do blood gas, we do non-invasive, and also we monitor the set, the independent variable, and we monitor the measure variable. And we measure, look at the graph, and we look at the loop, and we do blood gas, we do X-ray. That's how we monitor a baby on a breathing machine. Now, there is any question is how we monitor a baby. Okay, I don't know why it's moving too fast. Let me do something. Because it's clicking by itself. And I think because of this. Okay, so now we will start by delivering oxygen. So we finished with monitoring. Now we will deliver oxygen to the baby. So remember that I was talking about the importance of how to give oxygen. And I need you to remember this very important. Oxygen is a toxic gas. It kills the human being. That's why Allah created us in a 21%. We cannot give oxygen more than 21% without certain precautions. First, oxygen should be humidified. That means through water to prevent dry secretion. Because dry secretion can obstruct the upper airway and the child will die within certain period because you obstruct, and then once you obstruct, it will cause a block, it will obstruct, cause collapse, and the child will be passed. That's one principle. Second, never give oxygen without monitoring the saturation. Don't start oxygen right away and the child is agitated. So you can keep the oxygen in a proximity to the mouth and nose by the care self, him or herself, until the baby is calmed down. So remember this principle: humidified, monitor, don't be aggressive. We can give oxygen by nasal cannula, and I will show you. A nasal cannula is preferred by face mask. The reason is it does not cover the mouth and the nose. So if you need oxygen for a long time, it's better to use nasal cannula. The oxygen is not flammable. However, it helps other parameters, other items, other materials to flame. So you cannot flame oxygen. But if you put a flammable substance with oxygen, it will ease the flame. So things like hair, skin, oil, clothes, furniture can get fire when there is oxygen nearby. And therefore, you should keep the oxygen cylinder at least 1.5 meter away from any flammable or heat source or electric device. If you use oxygen cylinder, first prevent from falling, check for leak, because if there is a leak, it can propel like a missile. It moves so fast and it can kill anybody. The cylinder should be checked, the regulator of the syringe, the gauge of the syringe, should be checked every day to prevent possible accident. We oxygen, as we said, the FiO2, we give it by percentage. The percentage going to the baby depend on many factors: type of the delivery device, which company manufactured the device, what is the flow rate, what is the interface, and the interface is the device or the tool between the tube and the baby, and the fitness of the interface. So the percentage of oxygen going to the baby depends on many factors. What are the type of the device we are using? Who manufactured the device? What are the flow in that device? And what is the interface? And whether that interface is fit or not. Now, is this slide clear? Any question about this slide? Questions? Okay. Now, based on that, we have what we call it blending table. Because remember, we have to blend the oxygen, which is measured by FiO2, fraction of inspired oxygen, and the flow by medical air. So based on the flow and the percentage, here we'll get the percentage going to the baby. So if we give a flow of 0.25 and 100%, the baby will receive only 34%. If we give 0.25 and 40%, so this is the measured, this is the set, so this is independent, this is the set, this is independent, this is the dependent, this is the measured. So this is what we set here, this is what we set here, so this is the flow set, this is the FiO2 set, and in between, so let me make it more clear so you guys can understand. So you can see this is the Blue color is the set. This is the flow, is the set. And this is the measure. So this is independent. This is independent. This is dependent. So if we give a flow of 0.25 and the FI2 of 40, the result going to baby is 22. Now see if we increase the flow, this flow by air, liter per minute, and we give the same, the baby will get 27. So please, the blending table is telling you. Now instead of using a blending table, the machine now will help you because it show you the set and the measure, the dependent, the independent, and the dependent. Now, do we understand the table? Now, you don't need the blending table in reality because the set, which is the independent, are showed by the machine, and the measure, which is the dependent, are also showed by the machine. So, set, measure, independent, dependent. Set, measure, independent, dependent. Now, is this table, the blending table, clear? Any question about the blending table? Please ask question. Okay. Now this is what we call it air oxygen blender. It blends the air with the oxygen. So you can see this is the percentage of I2, which range from 21 to 100. And this is the flow. And the machine blend the flow. So here comes the air, here comes the oxygen, and here's going to the baby or to the patient. So you measure the flow from here, and you measure the FI2 from here. Now you can see this is analog. So you look at the flow by number, but also there is digital now. So you put the number, and so you put the number of the flow instead of using dial, and you put the number of the FI2 instead of using this. So it depends how much you want to pay, you get the machine. But this is called air oxygen blender. And it will show us this table. Okay? Questions? Now, we will blend oxygen by different interface. Remember, we said that the oxygen percentage going to the baby depend on many factors. The delivery machine, the manufacturer of the machine, the flow, remember this flow, the percentage of FI2, but also the interface. So we can give a blow-by, which means that the oxygen provider is not in close contact with the baby. We call it blow-by. There is separation between whatever interface we are using and the baby. So it's in a proximity of the baby. So it usually we use the blow-by when the baby are frightened and just comes to the hospital before we give sedation and control the baby. It gives less than 30% oxygen, and we should use pulse oximetry before we starting it. If we give nasal cannula and we put the flow from 1 to 4 liters per minute, it gives us 25 to 40% oxygen. However, when the baby breathing spontaneously, the percentage of oxygen can be decreased. Now, in nasal cannula is 25 to 40 because it's affected by respiratory rate of the value of the baby. How many, is it 60 or 50? Second, tidal volume. How much volume are provided with one cycle? Second, because it's in the nose, when the baby opens the mouth, it affects also the oxygenation. People use 1 to 4, they call it. But some centers, the nasal flow, they keep it less than 2 always, because they say when you are more than 2, you irritate the nose. Now, are we understanding what blow-by and what is nasal cannula?
Well, I didn't understand the blow-by. Is it a type of any
By
oxygen,
when you give
supplying
oxygen
oxygen?
by any mean, any way, anything, but is not in contact with the baby. There is separation between the interface and the baby. I will show you pictures, and you will understand the blow-by.
Okay.
Nasal cannula is something you put it in the nose, and it should be limited by 1 to 4 liters per minute of flow. But some center limited to 2. And it gives us 25 to 40. Why this range? Because of respiratory rate, tidal volume, and the extent of opening mouth. Do you understand? And blow-by, I will show you the pictures.
Okay.
Questions? Simple mask, the interface, give us 35 to 50. Again, like others, it affects by spontaneously breathing baby. It also affects if the mask is fit and what is the respiratory rate. Now, partial rebreathing, I will show you pictures, give us more oxygen. And we use partial rebreathing when we have limited oxygen and we want to prevent oxygen from leaking out of the baby. Non-rebreathing, because there is no leak, non-rebreathe, the baby will not rebreathe its own. It gives us more oxygen. It gives us up to 95. And that's why when the baby is breathing spontaneously, if we use non-breathing, it will get more oxygen. Now, it's very important that should be very tightly fit on the baby. Hood, I will show you the hood. Tent, I will show you the tent. We don't use it anymore, neither hood nor the tent. Self-inflation bag, the ambu bag. If we use reservoir, hey. If we use reservoir, we can give up to 100%. But the good news about self-inflation, we can do ventilation with the oxygen. Self-inflation valve, we cannot use it by blow-by because there is no flow. Flow inflation bag give us 100%. Again, like self-inflating can provide oxygen, but also ventilation. We can bag the baby with it. Flow inflation valve, we can use it for blow-by because there is flow. It's a flow inflated. See, let me change this, okay? I have problem. Sorry about that. I really don't know why this happened. I never click this. Anyhow, let me go back. Now we'll start by blow-by. So we can use like any styrofoam cup, disposable cup, and put the tube at the beginning and put the mask or this tube or the mask close a proximity of the baby. We can use corrugate tube to give blow-by, and this is blow-by. You see what's blow-by? So the interface is not in contact with the baby. So it can be mask, it can be cup, it can be flow inflation, but it cannot be self-inflation. And it can be tube, and it can be a hand. So you use your hand like a cup and hold the tube. Okay? So you can see the blow-by. Do you understand the blow-by?
Yes, now it's clear.
Yeah,
It's
that's a
we
blow-by.
give oxygen, but not in direct contact with the infant or the baby.
Correct. Regardless the interface. So whether it's a flow inflation, whether it's a tube, whether it's a a styrofoam, whether it's a disposable cup, whatever, or your hand.
Okay,
And
thank
the
you.
reason to calm down, like here they are calming down the dog. Clear?
Clear, but يعني in blow by
Cannula.
there's no decrease in oxygen.
Again,
When we use blow by, it means that there's no decrease in any saturation, just for calming down or
we said the percentage. You still remember? We said blow by, we
less
provide
than
less
30.
than. Remember that?
Okay, thank you.
And
I get.
each method give us certain percentage. So when I record you go back and look at it and you'll understand. So repeat and you'll say, remember that we said each method have advantage and disadvantage. And the
Okay.
percentage. Okay? So the blow by give us around 30%. We use it first time when the baby is agitated, and it can be provided by the caregiver or the parent. Nasal cannula. Now people call it cannula, and sometimes we call it prongs. So the difference, the prongs are a little bit long inside the nose. So we have many types of, we have low flow, we have microflow, and high flow. The microflow, when the flow is 0.01 يعني 10 يعني 1 من 10 من اللتر 1 من 100 من اللتر إلى 0.09 0.9 from 0.01 to 0.9 from 0.02 0.03 0.04 0.05 0.09 0.1 0.2 0.3 0.8 until 0.9 all are considered microflow. Sorry, from 0.01 to 0.09. From 0.1 to 0.9 called low flow. From 1 to 2, as you remember in certain centers, but some centers say up to 4, called normal flow or nasal flow. When it's more than 4, it's called high flow. The importance of nasal cannula or prongs, if it's long, is to provide the oxygen directly to the baby. We are not covering the mouth. We are not covering the nose. So we can use it for long time oxygen support. It flows the oxygen directly to the nasopharynx. And therefore, it mixed with the room air coming from the mouth. And therefore, the delivery by nasal cannula affected by the respiratory rate, the tidal volume, the flow, remember the blending table, and whether the mouth is open or closed. So here is a nasal cannula. Any question about oxygen delivery using nasal cannula? On low flow, when the flow is from, let's say 0.9 to 4, some people say to 2. And remember, when we use low flow or micro flow or normal flow, whatever the name you're using, we give 100% oxygen, 100% FiO2. So 100% going to the. Why? Because the flow from the air affect the percentage. So the set is 100, but what's going to the baby is 25 to 40 based on the flow we're using. Now, some centers say when the flow is more than 2 liters per minute, it irritates the nerves. And that's why it should be heated and humidified. However, when you are microflow, which means 0.01 to 0.9, you don't need to blend it, and you don't need to heat it and humidify. And that's why it's suitable for home oxygenation, the microflow. So we use it in chronic babies that need some oxygenation. And you see some movies, a gentleman or a lady on a wheelchair and the tube is after her. So remember, when you use microflow, which means a flow from 0.01 to 0.9, you don't need to heat or humidify. Any flow more than 1 need to be heated and humidified. But remember, when you use it for a prolonged time, it can cause dryness and it can bleed unless you are heated and humidified. Any flow more than 2 is not recommended for newborn babies, and the CPAP is indicated. And the CPAP, usually the flow until 16 liter per minute. Anything above 16 liter per minute, we go to high flow nasal cannula. So remember, we have low flow nasal cannula below CPAP and high flow nasal cannula above CPAP. Questions? Any question here about nasal cannula, low flow, high flow? So low flow, used for low oxygenation. The importance of nasal cannula by low flow, it's very lightweight, it's very not expensive, it's mobile, and does not affect the eating. The limitation is we cannot use it in a sick patient. The microflow, we give 100%, and we don't need to use heated, humidified oxygen. Therefore, it's very good for weaning from oxygen, chronic oxygen therapy, and home oxygen therapy. Now, there are something called Venturi system when the flow can be changed. Because remember, when we give a flow, it's fixed. You cannot change it. But at the bottom, at the end of the mask, sometime we can change the flow. If that mask have this capability or this feature, it's called Venturi system. So it's Venturi system with nasal pump. Now, do you understand what's microflow? And what is low flow or normal flow? And what's high flow? The high flow need heated and humidified. And there are many devices for high flow. We have the Vabotherm, we have the comfort flow, and we have the OptiFlow. Okay, the high flow is any flow above the CPAP level. It's usually more than 8 in infant and more than 16 liter per minute in children and adult, up to 60 liter per minute. Now, between 2 or 4, depending on the center, until 8 in infant or 16 in children, we use CPAP. So microflow, low flow or normal flow, CPAP, high flow. Now, is that clear? Any question here?
Doctor, you mean that high flow deliver more oxygen than CPAP?
No, just flow. Oxygen depending on FiO2. So the flow here is from air. Only the flow depending on oxygen when you are microflow. Any other, you need to blend, heat, and humidify. So when we say blend, we blend air with oxygen. And heat mean we make it like a room, like a human body temperature. And humidified, we mix it with water. So anything above microflow, which means above 0.9, and some people say 0.5 actually, and anything above 0.5 liter per minute, you need to heat and humidify. So anything above 0.5, the flow depends on the medical air and the FiO2 coming from the percentage of oxygen. So we have microflow and we have low flow, microflow until 0.9 or 0.5, depending on the center, and low flow or normal flow from 1 to 2 in certain center and from 1 to 4 in others. Anything above 2 or 4 until 8 in infant and until 16 in children and adult is by CPAP. Above 8 in infant and above 16 until 60 liter per minute are called high flow. Anything above microflow, the flow is not provided by oxygen because it becomes blended by air oxygen blender. Clear? Or I should repeat? Question? Okay, I'm going to stop soon. So this is an example of Vabotherm, high nasal flow. This is another Vabotherm. This is the comfort flow, high flow. Oops, 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 oops. This is the optiflow. You see that happening always because of this. So I'm going to stop at the mask because that will be too much, and we'll continue next session from the mask. Now, when we start practicing and we repeat this in practice, you guys will memorize it on the heart. And you'll remember, after 1 year working with me, you'll see that you'll be a different person in medical care. Okay? Everything they taught you is wrong. Okay? So you thought you know, but it's actually you don't know. And now you will feel why when I deal with people who don't know and don't know resuscitation, why I'm frustrated. Because they bring you anesthesia person and they think they know. So this is optiflow. So I'm going to pass this talk about high flow. I don't want you to know. Now the mask, there are different type of mask, and we will talk about them later, not today. I will stop at mask and I will teach you masks next session. Okay, I'm going to stop here. I'm going to stop recording because I'm going to receive questions. Okay, question, comment, or whatever.